Vishesh.
Okay. Let us start, Apurva. Start it, please.
Okay, start. Start.
Good morning, sir.
Apurva,
Ah,
for the
sir.
benefit of introduce everybody. I think everybody has previously known. Okay.
Okay.
Fine.
Dr. Srinivasan, sir, he is a professor at Coimbatore. We have Dr. Andara Sahib, who is our own faculty at LG Hospital, is a professor of surgery. Dr. Shreya Butala, she is a medical gastroenterologist working at, I think, Noble Gastro. And Dr. Achala ma'am, she'll be joining. If you're not, she'll be joining in a couple of minutes. She is ex-HOD and superintendent at Sea Hospital and professor of surgery at Apollo Hospital at present.
Okay.
So first
good morning.
so Sahib, we'll allow him to complete the history part and a question pursue. And then after the examination part, we'll cover up everything. If you feel like that you want to interrupt in between, he is making some gross mistakes, you are free to do so. Okay, start.
Good morning, everybody. I am Dr. Rajesh Yadav, third year general surgery resident, student of Dr. Deena Shah ma'am, presenting a case of obstructive jaundice. 45-year-old male farmer patient, resident of Kutch, presented with chief complaints of yellowish discoloration of eye and skin since 1.5 months and associated with right upper abdominal pain since 15 days. History of presenting illness, patient was relatively asymptomatic before 1.5 months. Then he started complaining of yellowish discoloration of eye, skin, and urine since last 1.5 months, which was progressively increasing in intensity. Patient also complains of right upper abdominal pain, which was intermittent, colicky, radiating to back, and increases after meal, and not relieved by positional change. Pain is associated with low-grade intermittent fever with chills since last 10 days. A patient also gives history of single episode of vomiting containing ingested food 10 days ago. Patient is a known case of hypertension on antihypertensive medications this last 9 years, and there was no history of tuberculosis and diabetes mellitus. Patient is not previously jaundiced or having any history of blood transfusion or any previous operating history. Patient is a vegetarian by diet and has reduced appetite since last 1 month. Bowel, bladder, and sleep habits were unaltered. Patient is a non-smoker and non-alcoholic. There is no significant family history present. Summary of history. 45-year-old male non-alcoholic non-smoker patient presented with complaints of progressively increasing yellowish discoloration of sclera, skin, and urine for 1.5 months, associated with right upper abdominal pain and low-grade intermittent fever for 15 days with no other symptoms.
Dr. Raj Rishi,
Yes.
please go to your first slide.
Sir.
Second. So you have mentioned yellowish discoloration of eyes, skin,
Yes,
and urine. Do you mean to say that all three got noticed same day?
No, sir. No, sir. Patient was diagnosed by a friend that he's looking yellowish. Then he started noticing yellowish discoloration in the eye. After that, he started noticing discoloration in urine as well.
So I think this is history taking is very casually you have taken. I'm not criticizing you, but as a PG student who is going to become MS, you have to take history in that order which the symptoms developed, right? First, so yes. What do you think the first notification of patient himself should be, and why?
Yes, sir.
What will he
Typically,
notice first? What will he notice first?
So he will notice his yellowish discoloration of sclera first, sir.
No. Urine.
Okay.
Right?
Yes.
Okay. Can you tell me by what is the arbitrary level of bilirubin by which skin, I mean sclera and different parts of skin and other parts get discoloration, if you know?
Sir, when bilirubin level reaches more than 2, then symptoms starting. Then the symptoms started noticing by the patient. Up to 5, up to 8, sir, sclera is discoloration is present, sir. After that, skin, sir.
Okay. What about history of Bleeding? Do you think you should take
So
history
there was no.
of bleeding? Do you think you should take history
Yes.
of bleeding? Have you taken?
Yes, sir. Yes, sir.
Have you taken? Show me.
Sir, actually, the slide got mixed up and sorry,
No,
sir.
no.
It is
From
not
no, no.
written here.
It's fine. It's fine. Everything you say. No need to say sorry. See, this history is whatever patient has said. By this history, you can presume that you are dealing with one diagnosis, but you have to rule out what is the age of this patient.
It's a 45-year-old male.
Yes, so it's a borderline age, right? You have to rule out
Yes,
each and everything.
Yes, sir.
Right? So there is only intermittent colic radiating pain, radiating to back, and fever, right? And jaundice. This can be a
Yes.
medical jaundice, surgical jaundice, whatever. So how do you differentiate that this is colic is usually not colic is usually not medical, but still you have to rule out other history also. Next.
So there is no history of malignant.
This is the thing where you will be caught. Whatever
Yes.
investigation findings you say, this history is very important for PG student and for
Yes.
surgeons, right? So
Yes.
just we keep this part to go with next slide. Sir, anybody else? Srinivasan sir or Dr. Shreya?
Yeah, obviously, I would like to comment ki the history is missing quite a lot of things. So first of all, with this history, you are not able to differentiate whether it's a medical jaundice or a surgical jaundice. So was there any history of pruritus?
Yes. No, ma'am. There is no history of itching, sir. Ma'am.
Sorry to interrupt, Shreya, just a minute. Rajrishi,
Yes.
yesterday when you showed me the slide, it was there. Where has it gone?
Sir,
Even this cannot be excused. Sir, even
Ah.
this cannot be excused. Don't try to save him. You will
No, I'm not trying to say. I'm very much surprised. We had discussed all these, and because you think it. No, the point is not saving
So
him.
that means
You have omitted it. That's what I want to know.
he thinks that this is not necessary.
Exactly.
And
That's
he has
why I'm
taken it
asking
very
why you
casually.
omitted it. That's what I want to know.
Let me tell you, Dr. Raj Rishi,
Yes, sir.
everybody is spending their Sunday morning crucial time, and you have taken it very casually. The way you first year or second year presents the case or history in his senior's round, and it is ultimately who is at loss? You only. And
Yes.
the student sitting here waiting for exam in few months, everybody's time is lost. I'm not saying that it's a fault, but you should take it very seriously.
No, I'm interested. Why you omitted that part?
That's
what I want
sir,
to know. What is
sir, I have-
significance of that?
sir, I have not.
Pruritus?
Sir, I will compare it with our Indian batting in test match. T20.
Let him
Sir,
tell the reason. Let him tell the reason.
Sir, I have not omitted. There was a slight mistake, and the slides is incomplete, sir. I have to shift from my laptop to iPad. I have the points are there, sir, but in this slide it is not showing.
Okay, forget about it. Answer the question of Shreya. Why
yes,
the
sir.
itching or pruritus is important?
A high level of jaundice leads to deposition of bilirubin in the skin, sir, which leads to itching.
No. What is the reason for high level of jaundice? Bilirubin. Is it common in all jaundice?
No, sir.
So that is what the history is.
Sir,
So
if the,
what it helps to differentiate? Pruritus, what it helps to differentiate?
there is a increased level of conjugated bilirubin in the patient's body, which is getting deposited.
No. So there is associated history of clay-colored stools.
No, ma'am, there is no history of clay.
So that was also not mentioned in your history. So why it's important? What does clay-colored stool signify?
UG question, doctor.
Okay, Rajrishi, just
Yes,
take a deep breath. Just take a deep breath. We can understand it might be a simple mistake or that. Forget about your mention or not, that's fine. Madam is asking very simple question, which has been asked to you in board many times. What is significance of clay color stool? Let us start with what does the clay color means?
Steatoria, sir. It means steatoria. Patient is not
No,
able to-
absolutely no.
Which is the test to know that there is steatorrhea? Let me divert you now to anywhere else. What is the test to know that patient is having steatorrhea?
And what is
Sir.
steatorrhea?
Steatorrhea.
It is a test for malabsorption, sir.
What investigation you will advise?
So as to I will
Name
like
of
to
that
get
test. Name of that test. See, so in short, you don't misfire your answers. Clay color stool is a typical diagnostic of
sorry,
what?
sir.
Take a glass of water and then answer. Just relax. Don't get disturbed.
He has lost it.
Yes,
Rajrishi,
yes.
take a deep breath. We wait. Don't worry. You are confused now. Clay color stool with steatorrhea. Steatorrhea presentation investigation is different. We are talking of a obstructive jaundice. So it is a very simple question. Clay color stool. What is clay?
Some a mud, sir. Typical color of mud.
So why it is known as a clay color stool? And what is reason for that? Very simple question is being asked.
What is absent in the stools?
Has it anything to do with level of or type of obstruction?
What doesn't get absorbed?
I think
Sir,
Shreya, better answer him. He is gone now. I think he is now confused.
Rajarishi, listen. Relax.
Rajati, you know the bilirubin
Complete obstruction, intermittent obstruction, partial obstruction. Now can you answer? If there is complete obstruction, what will happen?
sir.
Bile
There
will not come to GI tract.
sir, there will not be reabsorption of the bile through enterohepatic circulation.
Absorption is okay, but the stool will not be stained. What is the stain?
Stercobilirubin, sir.
Okay, carry on.
Okay, let us say. So why did you ask history of clay color stool? What was there? Why normally in a patient of obstructive jaundice, we ask history of clay color stool?
To differentiate what?
Very simple question again. Do you understand what happens in obstructive jaundice?
I have given you the hint, beta. Complete obstruction, partial obstruction, intermittent.
Anyway, what is definition of obstructive jaundice?
Sir, there is a obstruction in the drainage of the biliary system, sir.
Okay. If there is obstruction of drainage, what will not enter the GI system as the Hitesh bhai asked?
Sir, bile will not get.
Okay.
Into the
So
GI
what
system.
happens to bile once it comes through the GI system?
Sir, there will be deconjugation by the bacterial. Sir, the GIT bacteria will deconjugate the bile. There will be reabsorption, enterohepatic reabsorption will be there, and some
what
of the
is
bile
not reabsorbed? What will happen to that part which is not reabsorbed?
It will get excreted. Bile salts and bile salts will get excreted.
Kindly read bile metabolism.
Pruritus is a sign of which type of jaundice? Rajrishi. Yes.
Yes, sir.
Can it happen in medical jaundice?
No, sir. Medical jaundice can give.
My question is yes or no. Can it happen in medical jaundice or no?
No, sir. Mostly unconjugated in medical jaundice. There are
No,
unconjugated.
it can happen when there is cholestatic phase, right? Even
Yes,
in pregnancy, it can happen.
Yes.
Right? How will you? Okay, carry on. Next. What about hematemesis, melena? What about history of bleeding PR and then relieving of jaundice? Are these
Sir,
questions important?
Yes, sir.
And what does it signify?
Sir, if the patient is suspecting malignancy, they will shedding of tumor mass, sir, which will
Okay.
which will be
Which
presenting as
tumor?
melina. And
Which? Okay, carry
yes,
on,
sir.
carry on, carry on. Then I'll ask. Carry on.
Sir, the periampular tumor most of uh,
Your voice is missing.
there will be hello. Am I audible?
Yes, yes.
So there are two types of jaundice: intermittent and vaccine and waning. In vaccine and waning of jaundice, there will be in periorbital carcinoma there will be vaccine and waning of jaundice, where in between the tumor mass will shed off, so the obstruction will be relieved.
All periampullary?
No, sir. Pancreatic head of pancreas will not show this.
So you can say ampullary growth, right?
Ampullary
Why it shades off? Why it
sir,
shades off?
due to the growth of the tumor, sir, there will be the vascularization will not be sufficient, so it will shed
Yes.
out.
Yes. So then what will happen?
The obstruction will get relieved, sir.
Patched to some extent. Yes. So that
yes,
how will patient come
and,
to know that my jaundice was relieved? How will patient give history, and you can come to conclusion that this is that type of jaundice? What will you ask, or what will patient say? If patient is literate, what will he say?
So there will be decrease in the intensity of the jaundice, but never reaching the normal value.
You will not say that my intensity decreased. What are the features, symptoms which are relieved by relief of jaundice?
So the itching will decrease, sir. The symptoms of itching will get decreased, sir. The urine discoloration will go to normal, and the sclera will get whitened.
Sclera will take long to get depigmented. So patient may feel feeling of well-being. If his appetite was reduced, he might get some improvement in all this. Okay.
Yes.
What about history of hematemesis? Do you think you should ask?
Sir, as such, sir, hematemesis will be, sir, I will, if the hematemesis will be present, sir, I will see that the ampullary growth is eroding the.
No. Should you ask history of hematemesis or not in a case of jaundice?
Yes, sir, for completion sake, I will ask, sir, but melina is more important in this obstructive jaundice, sir. Hematemesis.
Are you sure that you are dealing with surgical jaundice only?
No, sir. But if obstructive jaundice leading to
what are the causes? What are the causes of jaundice?
So jaundice can be divided into, sir, three pre-hepatic, hepatic, and post-hepatic. Sir, in pre-hepatic there will be the hemolytic disease will come, sir, which gives rise to more unconjugated bilirubin. In hepatic causes there will be there will be medical causes like hepatitis and cholestasis. And post-hepatic will be there will be obstruction in the drainage system.
So
which will
in which jaundice there can be hematemesis? Can portal hypertension lead to jaundice?
Yes, sir.
Or cirrhosis lead to jaundice? Patient can have portal hypertension. It can coexist together. So all histories are very important. Histories of any drug abuse, histories of blood transfusion, right? Drugs side effects. So in short, let us move to other slides now. So much things are missing in history. Just prepare yourself again, right?
Yes.
One thing I like to tell every student on this platform: hypertension, tuberculosis, diabetes are not past history. What do you call them? Comorbidities. Comorbidities. Here, all the past histories which are possible, you have missed. Right? Carry on. Next. History of jaundice.
History of diabetes.
History of jaundice itself is important. Okay.
Yes, sir.
Recent
sir, I have
recent
sir, I have mentioned.
Let's listen to
history of diabetes
sir.
mellitus. Is it important?
Yes, sir. Yes, sir. The development of diabetes in young patient with obstructive jaundice, I will if there is a carcinoma head of pancreas, patient will recently develop diabetes, sir.
Okay. In waxing and waning, do you think the bilirubin level will come back to normal?
No, sir, never reaching the baseline, sir.
It never reaches the baseline. You had put an intermittent colicky type of pain
Yes, sir.
with chills.
Yes, sir.
That is a predominant history which you have made. The pain is associated with grade 1 intermittent fever. What do you think in this mind if it is? What could be the cause?
Sir, patient due to stasis of so due to have might develop cholangitis, sir, which is showing as a fever.
Okay. Proceed.
Next. So probably from this history, we cannot presume what you are dealing with, right?
Yes, sir.
Or you cannot rule out what you are not dealing with either. So this is what the motto of taking history is. Next slide. Go to examination. Go to examination.
Yes. Sir, in coming to general examination.
एक मिनट पीआरएम सर हमारा की पूछू है कि श्रेया डॉक्टर श्रेया
Yes.
Okay, continue.
Just a minute. I had a phone, so I went for it. Hello, I'm audible?
Yes, sir. Yes.
What I want to ask is, so you said something about surgical jaundice. What is that? What is surgical jaundice?
Sir, surgical jaundice is something which can be corrected by surgery, sir. Mostly due to
So the case you are dealing with, is it a surgical jaundice or obstructive jaundice? Probably.
that is obstructive jaundice.
Okay. So what is obstructive jaundice? Come back again there, because that histories you have not taken are very important. So what is obstructive jaundice?
Sir, obstructive jaundice is the jaundice developed due to the obstruction in the drainage of the bile. It can be due to interabdominal or extra compression from the outside, sir, of the common bile ducts.
Okay. So what is intrahepatic jaundice?
Sir, yes, sir. Patient development of jaundice due to the cholestasis. It can be due to the yes. It can be due to various causes, sir. It might be due to pregnancy or any drug intake, sir.
So, can there be a surgical jaundice without obstructive jaundice? Do you understand my question?
Yes, sir. Yes, sir. Yes, sir.
So, can there be a surgical jaundice without obstructive jaundice?
Sir, primary sclerosing cholangitis leading to sclerosis of the biliary duct can
that will be
give rise to jaundice.
That will be obstructive. It is not a surgical again.
Yes, sir.
So what happens if patient has a hemolytic jaundice?
Sir, there is a overload of the bilirubin to the liver, sir, which
so
the liver
jaundice,
is not,
and it is not obstructive jaundice. So when you are dealing with hemolytic anemia, it can be a surgical jaundice without obstructive jaundice, right? So have you asked history for that? So what are the history you will ask for that? That patient might be having a hemolytic anemia.
Sir, I will ask about the previous any previous admission, sir, or there will be or any family family member.
Was there a previous jaundice or previous admission in this patient?
No, sir, there was not.
You have asked?
The past history is absolutely missing, and in that you have mentioned comorbidities, right? Past history is very important in such cases. Past history of jaundice, anemia, blood transfusion, any drug adversity.
Have you asked history of blood transfusion?
Yes, sir.
Yes. So why will you ask history of blood transfusion in this patient?
Sir, two causes, sir. If there had been a recent blood transfusion, 12 to 24 hours, there will be immediate, due to incapacity, there will be immediate jaundice developed within 48 hours. And if there is a sir, if there is any not properly treated blood is transfused, sir, there will. Yes, sir.
Rajrishi, please stop.
Yes,
Are we in a medical case or a surgical case?
surgical case.
So will I be worried about jaundice in 48 hours in a blood
No, sir.
transfusion? For
No,
that
sir.
reason, you will ask history of blood transfusion?
No, sir.
What is the reason for asking history of blood transfusion?
Sir, so to rule out transfusion-related hepatitis, sir. There is a transfusion of SCV virus which can give rise to hepatitis in 6 months, sir. And another is I will think about anemia. Patient might have developed melena or hematemesis in the past days, which have been corrected by blood transfusion.
One is that, okay. That's what the Hitesh sir was asking. History of blood transfusion, a patient has a repeated anemia. That goes in favor of possibility of hemolytic pause. Any other reason? So what, suppose patient gives history, I had a blood transfusion before 20 years. And now
Yes.
patient comes with a hepatomegaly and jaundice. What will you suspect? Okay, we take it for that is obstructive jaundice. It can be something else also. So you have to ask history for that.
Yes, sir.
So if patient gives history, I had a blood transfusion before 20 years. And now he or she has come with the hepatomegaly with jaundice. So is there any reason for that?
Why do you ask history of blood transfusion to all patients, even if probably you are not dealing with such symptom? You need to ask history of blood transfusion. Why? Particularly 20 years back. Nowadays, it may not develop. But when the history is 10, 20, 25 years ago, what was lacking there and what can it lead to? Complications of transfusion?
Sir, there might be a transfusion related, sir, ICV infection, which might have developed to
what?
sir, HCV,
What is
sir.
common? What is common?
Hepatitis C, sir.
Hepatitis?
C, sir. Long term. In long term.
Okay. B is also not uncommon, right? B is also common,
Yes.
particularly a few decades ago.
Yes.
That can lead to all types of complications of hepatitis B.
Rajrishi, do you understand? Blood transfusion history is very important in all patients of jaundice. Because just now, for all PG students, you cannot put it as a yes, this patient is having obstructive jaundice. Patient is having a jaundice at present. In this patient particularly, there is no itching, no clay color stool.
Yes.
So you cannot reach to the conclusion that it is obstructive jaundice. So you have to rule out all causes that include hematemesis, because patient might be having a hidden portal hypertension.
Yes.
With liver failure.
That's why history of hematemesis I was asking.
Yes,
and one
I knew.
Sometimes you might have missed the history of blood transfusion, but you must be able to answer why you should ask. That is how you should prepare. You should never forget history of blood transfusion in any patient, those who are admitted at least. But if you have by mistake also missed it, you should be able to answer what are the reasons for taking such history.
Yes.
And another important thing is you need to ask the history of ascites also.
Right.
Yes, ma'am.
Why ascites is important in this case? History of ascites.
Ma'am, if the liver function is failing, ma'am, there will be development of ascites. And another is there is mets have developed in peritoneal metastasis have been developed. That there will be peritonitis as well.
So that was also
missing. How will you ask history of ascites?
I will ask for if there was any distension of the abdomen, or there was any procedure performed where there have been fluid which been drawn from the abdomen.
Fine.
Okay, great. So from history, your history summary, what do you think it is? Probably. Let us just, I don't want to ask any question, but we'll just ask, what are you suspecting from summary of history? Though you don't want to put anything. So is the jaundice? Okay, so forget, let us go to examination. Would you like to ask anything else? Anybody, please?
No, sir. Let us go to
Dr. Srinivasan,
examination.
Okay, let us go to examination. Purva, I'll be muted many times because the work is going on. It will be disturbing everybody. So,
Yes, sir. Yes, sir. Yes, sir.
okay. There is a background music going on. That's right. Okay. Thank you.
Coming to the general examination, I have examined my
Sir,
patient in
you
proper
can keep
daylight.
muted and press the space bar when you want to speak. That will be best option. Carry on.
Okay. Thank you. Yes.
Sir, I have examined my patient in proper daylight and exposure with consent. Patient is conscious, oriented to time, place, in person. Patient is fairly built and fairly nourished. Patient BMI is 29. Patient is afebrile on palpation. Pulse rate is 82 per minute in right radial artery. Pressure is 128 by 86 millimeter of mercury in right brachial artery by auscultatory method. There is a yellowish discoloration seen in sclera and skin. There is no edema or generalized lymphadenopathy, and the Karnofsky score is 80. On the abdomen is flat, umbilicus is centrally placed and inverted. There is yellowish discoloration of skin of the abdomen. There is no visible lump, no scars, dilated veins, or visible peristalsis was
Please
present.
go
Bilateral
to
hernia
full
slides
screen
were
mode.
normal.
Raj Rishi.
Yes, sir. On palpation, the palpation of abdomen has normal temperature and no tenderness. Liver and spleen is not palpable, and there was no palpable lump. On percussion, liver dullness was starting from 6 meters and extending till the right costal margin in mid-clavic line. There is no signs of free fluid present. On auscultation, normal bowel peristaltic sounds were present. Rectal examination was normal, and respiratory, cardiovascular, and central nervous system is unremarkable. Summary of the case. A 45-year-old male patient presented with progressively increasing yellowish discoloration of skin and urine for 1.5 months, associated with right upper abdominal pain and low-grade intermittent fever for 15 days with no other symptom. On examination, patient is jaundice with no itching and no clay-colored stool. On an abdominal examination, there was no palpable lump and no organomegaly was present.
Here the itching comes.
Sir, actually, the previous slide
No,
I
I
have
understand.
mentioned.
It can happen. It can happen. Particularly PPT is also difficult because everybody have photographic memory. Your subtle mistakes might take more time, more highlighted. Doesn't matter. Go to your examination first.
Yes.
So again, in summary, can you put some diagnosis?
Yes, where is your provisional diagnosis?
Yes, sir. My program section is obstructive jaundice, mainly due to which can be due to periumpty carcinoma, carcinoma head of pancreas, cholangiocarcinoma, and polyleucolithiasis.
Here I'll like to ask why periampullary carcinoma when patient has colicky pain. What are the features? See, you have to think logically, depending upon history and examination finding. So we'll come to that later on. Go to first slide of examination.
Yes, sir.
Okay. What do you think a patient of jaundice will have pulse rate? What are the effects of jaundice on heart rate?
Sir, it can produce bradycardia because the bilirubin can be deposited in the SA node, which can lead to conduction, decrease in conduction of the heart.
Okay, fine.
So anything missing in the general examination?
Yes.
A lot of things are missing in the general examination.
Your all examination slides are of few lines only. This is the biggest, having maximum number of lines or material. Inspection palpation is very short. You have to, in detail, you have to mention. What are the things missing here?
Madam, please elaborate.
So was there any
there is
pallor? Did you examine for anemia?
since patient was actorized, I cannot examine for pallor in sclera.
So where do you see
Where
for
do you look for
interest and where
pallor?
do you see for pallor? Pallor is seen in the icterus, I mean sclera.
No, ma'am. Patient is
Where
pallor
do you
seen in
look for
bulbar
pallor?
conjunctiva. Bulbar conjunctiva.
So what else? Did you see any stigmata of cirrhosis? What are the stigmata
Um,
of cirrhosis?
Yes, ma'am. Starting from there will be, ma'am, the signs of liver failure. There will be sparse hair loss will be present. There will be there will be gynecomastia. There will be spider nevi. There will be um, coarse hair will be present.
So did you mention any of this in the history? I mean your examination.
No, ma'am.
The examination.
Even the respiratory rate.
Yes, ma'am. I missed the respiratory.
Clubbing history of, I mean, did you see any clubbing was there or not?
No, ma'am. No clubbing was present.
You need to mention everything in the general examination.
Yes.
Have you bothered to look for clubbing? Tell me frankly.
Sorry.
That's fine. You have to stress on this.
Because the clubbing,
Also any itching marks, any skin
There was
lesions.
no
Pruritus.
itching. No itching marks was present, ma'am, on the patient.
Where will you see?
Where do you look for itching marks?
Excoriation also.
Where will you see commonly?
I will see
Where do you
in the
look for
abdomen
itching
as well as in the legs, shin of the tibia.
Extensor,
Abdomen and shin of the tibia.
extensor aspects and the abdomen.
Yes.
Extensor aspects of the limbs and the abdomen.
Yes.
So you missed bit, no problem. Note it down and correct it.
Raj Rishi, Madam has
Yes, sir.
asked about clubbing. Sir has also. Why clubbing is very important in this?
Sorry, if there is a anemia which leads to cyanosis and leads to chronic anemia.
We are discussing which case?
Surgical case. Sorry.
What is clubbing?
Sir, the nails of the patient, there is a parrot beak shaped nails of the patient, sir, which.
Now, is there an angle? Name of the angle? Levy
I
bone.
can't remember. Yes, sir. It got obliterated in the clubbing, sir.
Now, how many stages of clubbing are there? Since Madam asked, I'm just asking you.
Sorry, sir, I can't.
This is the lesson for all PGs. Don't consider any part as a trivial. This is a basic thing and your whole viva may be over here.
If you are speaking or everything fluently, examiner might skip. Okay, carry on, go to examination. You will get credit in short if you have lack of time. But if you miss this, probably you will not be able to go. See, it is already 9:46. We started 5 minutes later. 40 minutes have already passed, and we are stuck up at the level of general examination. So if this happens in exam, probably it will create a lot of problem.
Now, I would like to tell all the postgraduates kindly, not only reading the which clinical examination book you read, kindly read Hutchison's clinical methods.
Yes.
Because what is anemia, they'll ask. What is diarrhea, they will ask. Basic questions. If you are, as Professor Hitesh said, if you don't answer what is diarrhea, what is clubbing, what is anemia, your examination will be over by this one. So the basic things you read, please, see, go and read what is clubbing, what is the angle name, what is the normal, and what are the types. Like this, you should. So kindly read Hutchison, okay?
And make a habit of getting all these things done when such patients get admitted in your ward, and try to teach or ask your juniors. I think that is the greatest way to prepare for your exam.
Yes, excellent suggestion. And your this tenure is considered as a teaching experience. So it is your duty also. Srinivasan sir, can you elaborate little bit and for the PG's benefit, that clubbing angle and that? Because the most of them, I am very sure if we ask Half of them will not know. Please, sir, if you don't mind.
Kindly excuse, sir. I'll recollect and tell before.
The one mistake Rajrishi do, why this all happened? You have written Karnofsky index and that, but you have forgotten basic. The liver stigmata,
Yes.
you may not mention all of them because if not present. So
Yes.
simply write down there is no evidence of liver stigmata or no signs of chronic or acute liver failure. That will most satisfy most of the examiner. If he wants
Yes.
to ask, let him ask what are the stigmata, but you will have an upper end. Sir, I have examined for everything and it is not present.
A sensible examiner will not spoil the time of your examination, because when you have mentioned, it is understood that but if you you have not mentioned and say that I forgot, probably it is believed that you have not examined, right?
Yes.
Unless proved otherwise. So if you should have mentioned a few important things which are mandatory, positive as well as negative.
You have mentioned yellowish discoloration. What do you mean by?
There is a golden yellow discoloration of the sclera, which is indicating a deep jaundice, a high level of bilirubin. And it is due to
such a dark complexion patient. Are you sure the skin was yellowish discolored?
Yes.
Okay, fine.
The yellowish discoloration occurs due to in sclera due to deposition of the bilirubin in the elastin fibers. That's why it is yellowish discolor.
Why there are different color mentioned? What does it give you idea? This were all been
The level of there is a level of jaundice, sir. Different types of.
So what is significance of that level of jaundice?
Sir, in malignancy, there is mostly high level of bilirubin present. So there will be deep jaundice will be present, sir.
Yes, and
Hmm.
agreed. Very deep jaundice in other associate condition may suggest that. When it is a mild jaundice, again, this is a basic question that can be asked to you for all PGs. Remember, what are the common causes of mild jaundice, moderate or severe highway? Because depends upon that, it will help you to reach the particular diagnosis. Because when you will argue that this is a benign condition, malignant condition, hemolytic, so probably level of discoloration will help you. You cannot exactly say, but it gives you idea. Okay.
One more important thing, why do you see sclera in unexposed portion? Why do you need to raise the upper eyelids up and see for jaundice? Why can't you see around the eyeball? Everybody should read this. These are physiology. Any idea?
Sir, sorry.
Do you get my point?
Yes, sir.
You have to raise the upper eyelids, right? You have sclera. You have sclera around the eyeballs. Why can't you see there significantly? Unless patient is having very high jaundice. To see a minimal level of discoloration, you need to see unexposed portion of sclera. Why? The exposed portion is getting exposure of ultraviolet rays,
Yes,
right? So it
yes.
is. So now you read the physiology and you will get to know the answer. Next.
Now, there are 4 stages in clubbing, sir. One is there is fluctuation of the nail bed. Number 2 is obliteration of the low-V bond angle. Third, you have the parrot beak appearance. And fourth, you have the hypertrophic osteoarthropathy.
Okay.
Where
I was
you get
interested.
you get in severe pulmonary fibrosis.
Thank you, sir.
Welcome, sir.
Okay.
Madam, any questions?
You are supposed to know about unexposed part, why it is there, because the exposed part may not give you exact idea. Same thing goes for the how will you examine for yellowish discoloration? Very basic question.
Oh, have you mentioned breathing in inspection? Very important things.
No, sir.
Why do you need to mention breathing? So many things are missing, but breathing. Why do you see whether the patient is having abdominothoracic bleeding or thoracoabdominal? What is the basic difference in male and female? Do you know? Or you can mention it in general examination also. Okay, carry on.
No, yes,
Abdomen
but
is flat.
it is right. We were discussing general examination, respiratory
Yes,
rate and type of breathing. Yes, it is important.
Yes.
But if you are not,
Yes.
you can also mention in inspection of abdomen also. Both way it is fine, but you must mention it.
Better it is in general examination.
Yeah,
Because
I agree.
you will
I
not miss it.
absolutely.
You will not miss it in any case, any abdominal case.
Exactly. It is important. So it is better in general examination. Go back one slide again. Okay, so there are so many things missing. Again, the point is that you should also maintain the order, which thing comes first. So if you maintain that order, you will not forget the things. You have written so
Head
haphazardly.
to toe. It is said head to toe.
Exactly.
Yes.
So here the afebrile is first, pulse rate comes next, blood pressure, and then yellowish distress. We always start with tongue, conjunctiva, nail. Do you understand?
Yes.
Level
Yes.
of consciousness, and then you go down. So if you do not maintain that, when the respiration will come, you will know it. So this is the way to remember and keep it all the time.
Yes.
Right?
Yes.
And the
Level
For
of-
God's sake, read basic text examination clinical science book, which have mentioned everything in chronology.
Yes.
The thing is, we mention only things what we do in OPD and admit. We are in hurry. We have overload, most of us. So you have to make habit.
Yes,
Respiratory
exactly.
thoughts.
In all patient,
Yes, yes.
Yeah, so
If
many
it's a
things you
habit,
will never forget, clubbing, cyanosis. You should remember this, respiratory rate. That's fine. Great. Okay.
So 2 points what PRM sir said. One is the level of consciousness that you have not written, and second is the sleep pattern. Are they important?
Yes, sir, they're important. If the patient is sleep is altered, it might be due to intractable pruritus, which patient due
Is
to which
it-
patient is
Are we bothered about his altered sleep or something else?
sir increase intractable pruritus can give rise to sir increase disturbance of sleep.
And what about hepatic failure?
Altered consciousness due to hepatic failure can hepatic failure leads to alteration in altered consciousness.
What I observe from his history part is that he is predetermined. This is a case of obstructive jaundice, probably periampullary carcinoma. So he's simply omitting everything else. Remember, this is in true sense a case of jaundice. Just remember
Yes.
it like that. At the end of your examination, you will reach what it is. So do not miss anything related to liver or spleen or jaundice. So then you will
Yes.
not forget, because patient might be in liver failure. You don't know. How will you know that?
Yes.
So examiner will be interested in all these things. Do not means you are giving only information pertaining to the patient is having periampullary CA. So that is bias. It should not be there. You might have read reports and then taken a history. That's a different thing. But remember, for all PGs, consider this a case of jaundice. It is a wrong heading we are giving, case of obstructive jaundice. We prove at the end that it is a case of obstructive jaundice, but you are predetermined. That's why you are having so many problems. So all PGs, just consider it as even though you have seen the report, consider, yeah, it's a case of jaundice. So what are the things I will ask in a jaundice? Please, local examiner.
So on for abdominal examination inspection, the abdomen is flat and because it's centrally placed, inverted. The yellowish discoloration of skin or abdomen is present. There is no visible lump, no scar, dilated veins, or visual peristalsis. Bilateral hernia size were normal.
In such a dark skin, is it possible to make out the yellowish coloration of the skin?
Sir, it was evident in the patients.
Was the patient fair enough to note the yellowish discoloration of skin of the abdomen?
No, sir. Actually, patient was dark complex.
Will it be able to? You will be able to look out?
No, sir.
Yeah, proceed.
On palpation, the abdomen has normal temperature, no tenderness. Liver and spleen were not palpable, and there was no palpable lump. On percussion, liver dullness was starting from the 6 intercostal space, extending till the right costal margin in the mid-clavicle line.
Go back. That's it. Palpation. What is this, beta? What are the things to know in liver, abdomen examination palpation?
Sir, in palpation, I will see for any organomegaly if the liver is
First
palpable or
thing,
not.
temperature, tenderness.
Yes, sir.
Basics. See, even UG level findings are not that. Sorry to say. That doesn't mean
Absolutely agree. Absolutely agree.
That doesn't mean you don't know, but it's a question of habit. You have taken it very casually, beta. I'm sorry to say, but very casual approach. That's why what you should do today and today only, you have to read as Das.
Yes, sir.
The basic history taking an examination, general examination, and then abdomen examination for this case. Right?
Yes, sir.
Carry on. So many things, free fluid, hernial sites, back spine, external genitalia.
On percussion, sir, the liver dullness palpable was starting from 6 intercostal space and extending till the right costal margin in the mid-clavicle line. There were no signs of fluid present. And on muscle, normal bowel peristaltic sounds were present. On parectable examination was normal, and respiratory cardiovascular center system was unremarked.
So based on your examination, after history and examination, what are your differential diagnoses?
It is obstructive jaundice most commonly. It can be due to perineal carcinoma, carcinoma head of pancreas, cholangiocarcinoma, or polydocolic.
So your first diagnosis is a periampullary carcinoma. What is Courvoisier's law?
According to Courvoisier's law, in a jaundiced patient, if the gallbladder is palpable, it is seldom due to stone.
So you have a palpable gallbladder or a non-palpable gallbladder?
Gallbladder was not palpable in this patient.
So your malignancy is wouldn't be the first a differential diagnosis. So why did you keep periampullary as your first diagnosis? What are the symptoms which point towards periampullary diagnosis as the first differentials? Do you have any positive points to support periampullary carcinoma as your first differential?
Sorry, ma'am. The patient has a severe jaundice and patient's age, ma'am. Patient is on the borderline leading to illness.
So patient can have a CBD calculi also.
Yes, ma'am.
So that should be your first differential diagnosis based on this. Because you don't have a palpable gallbladder. What all?
There are some exceptions to Courvoisier's law as well. It is
But
not.
you have pain here. You have pain here. The
Yes.
symptom. Right?
You have pain, fever.
Fever.
Yes, sir.
So
No
how do
scratch
you?
mark, no scratch mark, no palpable gallbladder, no organomegaly, no free fluid. I don't mean to say that these are present in all the cases, but there is not a single hint to put periampullary as a first provisional diagnosis. The only, not a single thing. Progressive jaundice can be there you yourself are telling there are exceptions. So why not the other exceptions? What are the exceptions of Corbusiers law?
Sir, there is double obstruction, sir.
See, tell me in which obstructive jaundice due to periampullary carcinoma, a gallbladder will not be palpable. Let me ask you in that way.
Sir, if the patient has a previous history of cholecystectomy, obviously there will be a not palpable gallbladder. And
please repeat.
Previous so patient has a previous history of cholecystectomy is present, sir.
Obviously.
In patient.
Obviously. Then any patient where there is what you call gallbladder is there and not palpable, is it possible in a periampullary carcinoma?
Sir, if there is a no, sorry, sir.
So you have to think twice before putting this chronology.
So your first three differentials, they go against your examination findings.
Yes.
So what are the points favoring benign obstruction versus malignant obstruction? How can you differentiate between them?
Patient has a painful progressive jaundice, and patient has not given any history of vaccine and weaning of the jaundice one. And yes.
So what does it favor?
Since most commonly, sir, if the jaundice due to malignant case will be paleness and progressive, and there will be vaccine in case of ampullary periampullary carcinoma. There will be vaccine waning present. In in case of benign obstruction, mostly due to stone, there will be intermittent jaundice instead of vaccine waning of the jaundice.
So, but pain, fever, and jaundice, it favors your choledocholithiasis.
Sorry, patient might have developed cholangitis as well.
So, in which malignant cases cholangitis is common?
Sorry.
So how will you proceed with the case then?
So I'll go for blood investigation first. I'll look for the total count as well as hemoglobin for this patient, and then I will go for the liver function test. I'll see for the liver.
I think specifically when previously when we were discussing, they asked about hemolytic anemia. So in the routine blood, would you like to add something in a patient?
So if you are suspecting any hemolytic anemia, I will look for peripheral smear as well to see for the abnormal shaped RBCs and osmotic fragility test to rule out hereditary.
Before osmotic fragility?
Peripheral smear, I will like.
That is one peripheral smear. Anything else that will suggest hemolysis? Reticulocyte count always. You should go for count so that you can have a general idea whether hemolysis is going on or not, right?
Yes.
Okay.
Fine. What will you find in urine?
In urine, sir. In case of this patient, sir.
Yes.
Sir, urobilinogen level will be this, sir.
Urobilinogen?
Yes, sir.
Increased, yes. Or absent?
Yes, Sir, increased urobilin level, sir.
Increase urobilin. Yes.
Yes.
So urine, blood count, TCDC. Will the
Yes.
ESR be increased?
Sir, yes, sir. If infection is present, if there is a cholangitis associated as well,
No,
yes, sir,
in
will be
this
raised.
case, you said intermittent fever, vomiting, there is fever, intermittent pain.
Yes.
Will you get increased ESR?
Yes, sir, I will increase.
No. WBC count?
It will be raised, sir.
Yeah, you should tell
infection.
that one, sir. I'll do this one, and the inference which I get will be like this.
Yes.
LFT, what do you get?
Sir, I'll go for enzymatic as well as secretory function of the liver. So I will look for the HGPT, HLP, and alkaline phosphatase, as well as I will go for the protein time and albumin.
What
In case of
abnormality will you
obstructive
get?
jaundice,
What abnormality will you get?
sir, the ALP will be raised, sir.
Hmm.
In case of obstructive jaundice, sir, and
No, bilirubin.
there will be a
Bilirubin?
yes, sir. Bilirubin will
Which
sir
bilirubin
total
will be
bilirubin as
increased?
well as the total bilirubin as well as direct bilirubin will be raised.
Okay. Then, next.
Then I'll look for serum albumin and prothrombin as well to see if the liver secretory functions are normal as well.
Will there be any changes in the prothrombin time or
Prothrombin, so if the secretory functions are
you
not,
look for coagulation profile?
yes, sir, INR. I will also look for the INR.
Why do you look for coagulation profile?
Sir, if the liver functions are damaged, the patient, the liver will not be able to synthesize the secretory, the factors for coagulation, sir. So I have to look
What are
for
the
INR.
factors? What are the
Yes, sir.
factors? What are the factors?
So why do you expect coagulopathy in an obstructive jaundice with the normal liver?
Ma'am, it's normal liver, ma'am.
So INR of 2 in a patient with obstructive jaundice and INR of 2 in a cirrhotic. Which
Ma'am,
will be able to correct?
ma'am, obviously, ma'am, normal. If the patient liver is normal, functions are normal, I can give supplements of vitamin K since fat soluble vitamins are not been absorbed. The vitamin K and deficiency. So I will give vitamin K for to normalize the iron.
In which case?
Listen
In
to
which
what
case?
madam is asking. What was the madam's question? If a patient is cirrhotic and a patient has obstructive jaundice and his INR is 2, which one you are more bothered about and which we will treat?
Which you can correct actually with giving vitamin K. Both or anyone?
Or you cannot correct anyone.
No, sir, I can correct. With both I can correct. Vitamin K.
How do you correct?
Which you
cannot
will
correct.
be able to correct?
Yes, sir. Sorry, ma'am.
Giving vitamin K will correct INR in an extrahepatic biliary obstruction or your cirrhotic patient.
Extrahepatic will be correct.
Why it will be corrected?
Since because the vitamin K will get absorbed, ma'am. In obstructive jaundice there will be there is a problem in the absorption of vitamin K. So if supplementing vitamin K from outside and the liver function are normal, sir, so it can synthesize, it can have the vitamin K will synthesize help in synthesis. But in a cirrhotic patient, the
So
synthesis
vitamin K is a fat absorbable vitamin.
it
And
is
malabsorption occurs of the fat soluble vitamins in an obstructive jaundice because the bile salts are not secreted. They are not able to get into the intestine. So that
yes,
will be corrected, but not in a cirrhotic.
yes,
So another point in the history which you should be asking about the stigmata of signs of malabsorption of fat soluble vitamins
yes,
in your history and examination.
yes.
What is the non-invasive investigation you do?
Sir, I will first go for the USG for this patient. In USG, I will like to see if the about the biliary radical system. If there is obstruction, I will look for what is the level of obstruction, what is the diameter of CBD, and is the interhepatic biliary radicals are dilated or not. I will also look for the surrounding structures. Is there any thrombosis in the portal vein or not, or what is the status of pancreas? I will look for if there is a. I will look for liver as well. So to rule out any metastasis in the liver is present or not. I will also look for the fluid in the peritoneal cavity.
You look for the intrahepatic biliary radicals, the
Yes, sir.
dilatation of CBD, any
Yes.
stone. Will you pick up a pancreatic mass?
Yes, sir.
Is it possible in ultrasound?
Sir, I can status of the pancreas can be seen, sir.
That will be if it is hugely enlarged, edematous, or
Yes.
it is, I think you can feel a vague mass.
Yes.
What is double duct sign?
Sir, there is obstruction in there is the dilatation of pancreatic as well, common biliary duct. Give rise to dilatation of both the ducts. So there will be a.
What are both the ducts?
Yes, sir.
What are the ducts?
So pancreatic duct and common biliary duct.
What is the name of the duct? Pancreatic duct.
Yes, sir.
Is there a
Sorry,
name?
he's asking name of the pancreatic duct.
Oh,
There are two ducts, isn't it?
yes, sir.
What is Wilson and Santorini?
Yes, sir. Santorini is the minor pancreatic duct and Vishwa is the major pancreatic duct.
Accessory main duct of Wilson.
Yes.
So you can see if there's a double duct sign. What is the next investigation if you are asked?
Sir, sorry. Where do you look for a double duct sign?
Sir, if there is when there is obstruction in the lower part of the, so if there is ampullary obstruction.
Very good one. And it is the intrapancreatic part of both.
Yes.
Common bile duct as well as the pancreatic. There you will look for a double duct sign. And sometimes in USG, if it is good USG, patient is thin-lipped, which is likely to be, you can sometimes appreciate in ultrasonography also.
Yes.
But do not forget to mention the stones.
Yes.
In gallbladder as well as in the
pancreatic.
In the low CBD, common bile duct. What do you call it when there are stones in common bile duct?
Choledocholithiasis.
Choledocholithiasis. Right. So, what is the common presentation in choledocholithiasis? If you see in USG, come back in your history, which are the cardinal signs will suggest that patient will have a choledocholithiasis. In other words, in your examination, Hitesh sir was asking incomplete. So did you mention gallbladder is not palpable? What is significance of that?
Sir, gallbladder in this patient was not palpable, sir. Since if he has a suspecting stone in the common bile duct, it might be due to stones coming from the gallbladder. And since repeated stones in the gallbladder might give rise to the chronic choledocholithiasis, which gives rise to the fibrosis of the gallbladder. So it will become non-palpable.
What is Charcot's triad?
Intermittent fever, jaundice, and pain, ma'am.
What does it signify?
Ma'am, it signifies the presence of infection, ma'am. Mainly cholangitis.
What is the next investigation of choice?
Sir, if I am suspecting...
the ultrasound doesn't give, the blood reports are given you.
Yes, sir.
Increase in the conjugated bilirubin.
Yes, sir.
Okay. The coagulation profile is normal.
Yes, sir.
USG shows Now, inconclusive.
Yes.
What is the next investigation of choice which you will advise the patient?
Sir, I would like to for the magnetic MRCP for the patient to look for the anatomy of the biliary dialysis. If there is obstruction in which part, if there is stone present in the CBD or not.
So how will you decide you will go for MRCP or CT?
Sir, if I am suspecting any malignant, I am suspecting more toward malignancy, I will prefer for CCT. But if I am suspecting for an
What are you
etiology,
suspecting? What are you suspecting in this patient? You have written provisional diagnosis.
And
Yes.
probably the ultrasound says that the lower CBD is obscured, dilated,
Yes.
but they cannot say what it is.
Yes.
Your diagnosis is malignancy and you are still going for MRCP. Why?
No, sir. In case of malignancy, I will go for CCT.
In case nahi, we are talking of your case.
Yes.
So remember, probably you have got the report and that's why you are biased and that's why you are saying MRCP. So in exam, always go with your diagnosis. I am not
Yes.
saying your diagnosis should be right. It is
Yes.
a diagnosis. So when you are suspecting periampullary, why you are going for MRCP? Why CT is better than MRCP? Now it is a debatable, but let us say we still stick that CT is better. Why?
So in CT, we can also look for the if metastasis is present or not. We can see for the status of the liver. We can see for the peritoneal
We
mets are
can
present or not.
all these things we can see in MRCP also.
Sir, in CT, if sir, we can see the involvement of different structures as well, sir. If the urinum is small or not.
For a local part, CT is better.
Yes.
Particularly when you are USG suspect or you are suspecting, then you will be better. I think you have, I was a little bit out for that. You have discussed why you are putting a diagnosis of periampullary. Just now we have discussed?
Yes, sir.
Okay.
So sir, one thing, that why MRCP, if you are thinking of stone, why MRCP? Why not ERCP?
Sir, I will in MRCP I will get
The idea, the idea is that
anatomical.
the idea, what I feel is that if the patient has stones, and if you feel like that there are only a single or two stones which can be easily removed by ERCP, you should better go for ERCP. You get the same picture, and you get the clearance of the stone. Of course, we are not planning to go for an intervention of the stone through endoscopy. Then MRCP, being non-invasive, is better, and it gives you a better idea of the anatomy of the hepatobiliary system.
Yes.
You have a CECT pancreatic protocol.
Yes, sir.
You know Rajareshi?
Yes, sir. Yes.
Sir,
there are four phases.
Let me divert you. Who is Rajareshi?
Yes,
sir. Sir, sorry, sir. Just relax him.
No, it's okay. Does he know?
Who is Rajareshi in the Purana?
Can I answer this, sir?
Please, sir. Please, sir.
So actually, there are two things, Brahmarshi and Rajarshi.
Yes, sir.
Right? Rajarshi was Vishwamitra. Brahmarshi was the Vasishta. There is a dictum in a Ramayana that whenever Vishwamitra used to come, Vasishta used to call, please come Rajarshi. He was not happy. He was always wanting the title of Brahmarshi. But Vasishta never give him because you have not attained that stage. So we wish that you attain the stage of Brahmarshi, not the Rajarshi. Okay, thank you, sir.
Just tell me, what are the first? You have an early arterial phase, late arterial phase. Early arterial phase, 15 to 20 seconds. Late arterial phase is you have 35 to 40 seconds. Then hepatic or portal phase, you have 50 to 60 seconds. So you can write 15 to 20, 35 to 40, and you have a nephrogenic phase, which is 100 seconds, and delayed phase after 45 minutes. Okay. So in early arterial phase, pancreatic phase, you have the lesions of the pancreas related to the artery. Portal vein phase, you have nodes, liver, lesions related to the artery. This is what you should say. Okay.
Yes.
Sir, thank you. This was a very important. This is very important. I think
You
so.
can note it down. That's because that is
Yes,
very,
sir.
very important.
Yes.
We
Yes.
have now, you have done a CECT. Do you have a CECT of this patient?
Sorry, sir. I don't have CCT.
Okay. So CT was done or not done?
No, sir.
Why it was
These
not
patients are
done?
So what
Why-
was the
sir,
ultrasound
in-
findings?
Yes. Shreya, you wanted to say something, please.
Was ultrasound done in this patient?
Yes, ma'am. Ultrasound was done.
So what were the findings?
Show the finding. Raj Rishi, show the ultrasound. I
Yes.
think you have a plate. Or sorry, you have a report.
Yes, sir. Yes, sir. In ultrasound, sir, the liver was enlarged. There was a 10 size calculus was noted in the distal part of common biliary duct, which and there is the common biliary duct was 12 mm in proximal part, 20 mm in mid part, 23 mm in the distal part. The wall of common biliary duct was edematous and was measuring 4 to 5 mm, sir. GB appeared to be contracted with echogenic sludge. Wall of gallbladder was thickened, measuring approximately 4 to 3 to 4 mm. There was approximately 2 by 1 centimeter hypoechoic collection in the nodule adjacent to the fundal region of the gallbladder.
The final report.
So how will you manage this patient?
This was a
No, madam is asking, how will you manage
since stone was already since stone was visible in this patient. I will send the
Okay,
patient
Raj
for
Rishi,
ERCP.
before you go for a management, does this
Yes.
ultrasonography change your plan or diagnosis?
Yes, sir. My diagnosis will be now benign etiology of the obstructive jaundice, colorectal.
So how will you explain very high level of jaundice? What was the jaundice level? Because you said there
It
is
was
a deep.
Yes, sir. The total bilirubin was more than 25 in this.
And
So-
does this finding explain with your palpation for abdominal examination?
Yes, ma'am. There was no splenomegaly, no hepatomegaly. The gallbladder was not palpable. But
with a perforated gallbladder and with a localized collection, what do you expect in a right upper quadrant examination?
there will be lump formation and tenderness will be present in the right upper.
So was it there or not?
At that time, I examined the lymph was not palpable.
This is the problem. Many times, that's why I always tell them, do not
Work going on here.
Hitesh bhai, you are saying something, please.
There is some stone cutting going on around. So there might be. So these are the things which gives you hint that you are not probably thinking in the direction of malignant cause. And when you have these findings, why do you still selected to go for putting the first 3 malignancy diagnosis? This is my question is. I think logic, you must have some logic to put any provisional diagnosis. You may be 100% wrong in final diagnosis after investigation. But
That's fine. Sir is
that's
asking your
fine.
diagnosis fine, but why did you put that diagnosis? Right.
Yes, your approach is very important. It may be, many times we have failed in putting clinical diagnosis, but we should not fail in our approach to the patient.
Yes, sir. So since the patient was
doesn't matter. This is a greater. I'm always the believer that failure teaches us much more than success does. So please take this as a positive things with pinch of salt.
Yes, sir. Since patient was of middle age,
In Raj Rishi, just a moment.
And
Raj Rishi,
yes,
just a moment. Sir is asking very specific question. this report you had, still you put a diagnosis of periampullary. Fine. We don't have anything against it, but we want your logic. Why did you put a diagnosis of malignancy? I would have put the same, but why? That's the question.
Since the jaundice was very deep, sir, and the laboratory values of the jaundice was more than 25, total bilirubin of more than 25. It is rarely seen in the benign etiology that the so much raised bilirubin, sir. Even if it's the total obstruction, the level of the bilirubin is very high, sir.
So what are the points against malignancy in your history?
Sir, the patient has a painful jaundice, sir. Mostly there will be painless jaundice and malignancy cause, sir. Another is the patient has no complaint of itching, no complaint of melena, and no complaint of passing of clay colored stool.
And
Also, two
gallbladder
more
was
important things are there in your
There was
history
no
examination.
there was no palpable lymphadenopathy.
And
Uh,
already asked, Shreya has already asked you about that. Was gallbladder palpable or lump palpable in right hypochondria?
no, ma'am. No, the
so
gallbladder
that
was
also goes against your malignancy. Another
yes,
thing in your history.
yes, ma'am.
So why so? When the gallbladder is not palpable, it is unlikely to be malignant. Why?
Sir, because of the if the causes of stone, so there will be repeated cholecystitis will be present, which gives rise to fibrosis of the gallbladder. So uh, it will not become palpable.
The only point which even I don't understand, how come the 25 bilirubin? Shreya, can you explain that? I don't know why a patient should have such a high with a stone.
So sometimes the large stone can cause almost complete obstruction of the biliary system. So it can cause us, generally smaller stones will cause only partial obstruction. So you may get even a normal bilirubin or even a mildly elevated bilirubin, but larger stones will cause a complete obstruction. So it can cause severe jaundice. Sometimes the patient might have a concomitant hemolytic anemia. We have seen jaundice up to 52 also in patients with CBD calculi with hemolytic anemia with hereditary spherocytosis. So as high as 50 to 55 we have seen bilirubin. So just based on the bilirubin you cannot point that the patient is having a malignant or a benign obstruction.
What is the maximum level the bilirubin can rise? What is the normal pressure in the intrahepatic biliary duct?
So up to 45, patient bilirubin can be raised up to 45.
Normal is 5 to 10, it goes up to 30.
Yes.
So after that, even if it raises, it will not come. The bilirubin cannot be raised about 30 or 35. Okay.
Yes.
So in certain cases, we have seen 2 to 3 patients in certain cases with hemolytic anemias where they have a conjugated
Hemolytic
adenosine.
anemias, madam. But normally, what is your opinion, madam, please?
Yeah, normally we just see only till 30, 35, not more than that. But when there is an obstruction combined with hemolytic anemias, we have seen till 50, 55 also.
Yeah, 50, 55, madam.
Even in obstructive cases, I have seen 2 cases, 50, 52.
50.
But very rarely in this 30 years of experience, only 2 cases. Very rarely.
It's rare. I have also seen only 2 to 3 cases, but that was with hemolytic.
Many of us might not have seen 2. It is that rare. Absolutely, I agree.
Because after the pressure rises to the maximum level, what will happen is the bile cannot be absorbed, so it gets excreted.
Yes.
Yes.
Okay, Rajareshi.
Yes, sir.
Okay.
It is.
How we are going to manage this patient?
How will you manage now after USG?
Yes, sir. Since the stone has been seen in the USG, I will directly go to the ERCP and will see for the removal of the stone. Post that, I will go for cholecystectomy.
Madam, you can You can enlighten this full treatment,
Before
madam.
that, I would like to ask.
Stones.
Okay.
Yes, sir.
So
Sorry,
what
sir.
are the fallacy of your management? What can what can happen? The things which may not go well if you straightway go ERCP. Now you will not go for MRCP. Agreed?
Yes. Yes, sir.
Why not? Why not?
Sir, because I have there is a evidence of a stone in the common biliary duct, and so
The MRCP is only investigation part. ERCP
it is not therapeutic as
therapeutic.
ERP is therapeutic as well as diagnostic.
Let me make a statement. Let us discuss it. I will still like to go for CECT in this patient. Is there any justification?
Sir, to look for the status of the pancreas, sir, we can go for the CCT.
And there is a perforation.
Yeah.
Also.
Yes.
It was in the adjacent area to fundus of the gallbladder.
Right.
Yes, sir.
Okay. So what is the fallacy with ERCP in this case? What can happen? Shreya will be telling us in few minutes, but let us see your point.
Sir, store size is more than 18 mm, more than 15 mm, sir. So it might be a failed ERCP, which can there will the difficult removal of the stone. We have to go for the lithotripsy, which will break the stone to less than 15 mm, which can be removed, sir.
Shreya?
So for what would we doing the first?
Yes, sir.
So what all you can do in this patient with ERCP? So if you are not able to remove the stone.
Yes, ma'am. I will go for the spectrophotomy, sir, ma'am. Then I will go for the lithotripsy. I will attempt to break the stones in smaller sizes so that it can be removed.
So what are the methods of lithotripsy available?
So laser lithotripsy can be done, ma'am, with the use of laser.
Laser lithotripsy. Okay. What else? If still the ERCP fails, and it can fail because the stone is in the distal part of the CBD, you might not get access for passing the laser probe.
Yes, ma'am.
So what else you can do? If you are not able to remove the stone, what will be doing? How will you be relieving cholangitis?
Ma'am,
So
I will go for the percutaneous transfer. PTB. I will approach
So
from the
even a
bottom.
simple stenting, even if you are not able to remove the stone, a stenting will help to relieve biliary obstruction in this case.
Raj Rishi, in a
Yes, sir.
stone pathology, PTBD will be too much. Only when you are unable to do anything from below. As the Shreya said, I would like to put a stent first, even if I am unable to deal with, because you can see what does it suggest? CBD, description of CBD, thicken edematous. So, an evidence of cholangitis. Right?
Yes.
So, it may be a good idea to put a stent only, and then we can go further from that.
Yes.
You have to do some corrections before you do any interventional procedure.
Yes, sir.
Okay, Raj. Yeah.
Sir, I will hydrate the patient, and I will if I'm going for ERCP, I will give parenterally endomethacin.
You will hydrate the patient one.
I will correct for the anemia, sir. Any
Electrolytes, anemia.
I will, yes, sir. And before sending the procedure, I will give endomethacin directly to prevent the occurrence of post-procedure pancreatitis.
You have to correct the coagulation profile.
Yes, sir.
And also you are missing one important part.
Yes, madam. One more.
A very important thing.
Infection.
I will give antibiotics to these patients before correct.
Anything, madam, please.
Yeah, so antibiotics is very important. So initially you need to start with the antibiotics, and obviously you require to stabilize the patient with IV fluids, correction of coagulopathy, and then you
Yes,
need to plan for
Yeah.
any intervention.
Yes, sir.
What interventional procedure you want to do?
In this patient, sir, in this patient, I will go for ERCP guided removal of the stone, sir.
Madam, you can take over.
Let me ask you, because we are surgeons, why not straightway do a surgery?
Sir, for since the sir CBD is not much dilated, sir. 20 we can still go
How
for
much?
20 mm is the large dilated CBD. 20 mm, right?
20 mm is not much.
sir.
I think you
It is
rarely find 20 mm in benign cases.
yes,
So, and 23 in distal part.
yes, sir.
Hmm?
We
So
can
why
go for
not
sir.
surgery?
Yes, sir. We can go for sir. Direct. If the stone ERCP fail, we will not go for another attempt of ERCP. I will go for the choledochoduodenectomy
Uh,
or the
So you could
Rajrishi,
direct for surgery in this case.
Read the report. Wall of the CBD appears thickened and edematous.
that's what I am
Yes, sir.
asking.
So with this much of jaundice,
So, your
with
answer should,
cholangitis, you will directly go
yeah.
for surgery.
What Shreya madam is saying, that Rajrishi, even if you are planning, this is not the right time seeing at report. Patient is there, even a radiologist has mentioned cholangitis. So, if what will happen if you
Yes,
go for a straightway surgery? What surgery you are thinking? Suppose you are thinking of surgery.
sir. For surgery, I will go for choledochoduodenectomy or choledochoduodenectomy.
And what will you do to gallbladder?
With cholecystectomy.
You will keep it for later on lap chole?
No, sir. With
So,
same sitting, I will
the
not.
answer should be complete. So, will it be possible to do choledochotomy? Forget about choledochoduodenostomy at this juncture.
Sir, since the CVD wall is thick and endometrious, sir, the suture will give away if you go for choledochoduotomy and
I am
resuture.
talking of choledochotomy. I am not talking of choledochoduodenostomy. What is difference?
Sir,
What is
for in choledochod, sir, is generally patients common biliary duct and the stone will be removed, sir. Choledochoduotomy.
then what will you do?
It's going to, I will repair the CBD and this
How will you repair the CBD?
primary suturing, sir.
How will you repair the CBD?
Sorry, sir. I do not know.
Forgotten. Okay. So the best way is straightway go for a ERCP. If stone is removed, well and good. But even there, I think Shreya will tell you better, not the time to remove stone. Put a stent, give antibiotic, resuscitate the patient, and let the infection subside, patient feel better, and then only you should venture whether you go for a repeat ERCP followed by lap chole or straightway. Shreya, would you like to go and say anything?
Right, so this is the approach. I would like to stand first, stabilize the patient, and because the stone is stuck in the distal part of the CBD, removal with a laser, even a cholangioscope laser lithotripsy would be a bit tactful, and then we can proceed further based on the either lithotripsy or surgical exploration of CBD.
Yes. Okay, now the infection has subsided, everything is fine. How will you approach? That gastroenterologist has said now we are unable to remove this stone, but patient is stabilized, cholangitis has gone, patient feeling better, CBD size is 16 mm with stent inside with stone still stuck. What will
Sir, after stabilization of the patient, I will go for the CBD open CBD exploration, sir. And With that, open cholecystectomy will be done.
What will you do to CBD?
Sir, I will place the T-tube as well after the T-tube placement will be done in the CBC.
Okay. Why not now choledochorduodenostomy? Remember, time of T-tube, that was the, if you by accidentally you explore the CBD earlier and
Yes,
it found that CBD is edematous with pus and infection, even if you explore the CBD, you cannot close it primarily or you cannot do anastomosis. In that case, T-tube would be better. But once you have stabilized the patient and you have done this, you can do choledochorduodenostomy. In a benign condition, there is hardly ever role of choledochorduodenostomy. That is kept for a malignancy usually. Remember this point. Very rarely you do choledochorduodenostomy. Understand this point? That is the important point. Okay, one more point from surgical point of view. This is the report and patient, you have said it is everything is normal, but when I saw the patient, I feel there is a lump palpable. Patient's count is 15,000. Patient is having fever, having a right upper guarding, and gallbladder is perforated. Now, how will you approach this patient?
I will go for the exploration, sir. I will go primarily with the intention of removing the gallbladder, sir. And if I found in drop that
Rajrishi, again, there are two options available to us. One is you can take a help of gastroenterologist and do the stenting. It will have multiple ways. It will protect your CBD, give a good drainage, and you need not touch it at that time. One. Second, even if you have done stenting, you can explore the CBD and close the CBD over it thereafter stone. But this should be the last resort. The first is, because the gallbladder is bad, you may have to go for a surgery early. That should be kept in mind.
Yes.
And another point, and if there is a contained perforation, you can still manage with a percutaneous drainage tube if the patient is severely jaundiced. So percutaneous with an ERCP, you can initially tide over the initial crisis, and then obviously you can go for a surgical management later on.
What did she say? Did you understand, Rajrishi? What was the procedure?
Yes, sir. I will start percutaneous drainage, sir, of the.
What do you call it? What do you call it?
Of the
cholecystectomy. What is that?
Cholecystectomy. Sir, in which we put a drain in the we puncture the gallbladder percutaneously and we put the brain so as to drain the bile, sir, so the patient jaundice can be relieved.
Think anybody would like to ask anything? Apurva, Shreya? I think Hitesh is also gone.
Yes, sir. Yes, sir. Okay, sir, then.
What I want to say, one more important point, do you understand? What was the actual peroperative finding? That is real surprise for everybody. What was the actual peroperative finding? That's why they do not rely too much on only one investigation. And so if patient is stable in this patient, there is some justification of MRCP retrograde, let us say. What was the peroperative finding?
Sir, in the patient, the syndrome was present. Sir, the stone was impacted in the Hartmann bone and was making a fistula in the colloidal system with common biliary duct.
So what do you call it?
Mirizi syndrome.
Right. What are the types of Mirizi syndrome? I mean, there are
Mirizi syndrome can be, yes, Mirizi syndrome can be divided into 4 parts. First, there is only impingement of the stone and there is no actual occlusion or a fistula. In second, there is 1/3 of the circumference is involved. In the third, there is more than 2/3 of the circulation and of the circumference was involved. And in fourth one, there is a proper fistula with whole of the circumference of the CBD involved.
So how would you manage those patients?
I will go for the cholecystectomy as well, CBD exploration, and in this patient I will put the T-tube. T-tube will be placed.
Rajrishi, this is our But the point here is that how will you put a T-tube in a patient of Mirizi syndrome? I would really like to know.
If the fistula is present, ma'am, sir, I will through that fistula I will place the T-tube and the
Again,
sutures.
let me tell you, it will be very difficult. The best approach would be take a help of gastroenterologist and have a pre-operative stand if possible, even if there is no CBD stone in such cases. It will help you a lot. It is not
Yes,
a keep, it's a practical answer, not the theory answer. Do you understand? So that
yes,
will help many ways. Do you understand?
yes,
So if MRCP shows it is a grade 3 or 4 Mirizi syndrome, best approach is stand this patient and then go for a surgery. You can
yes,
in a bed because in a patient of Mirizi syndrome, there is a distinction between the end of the gallbladder and CBD is lost. You will
yes.
not know where the CBD starts and where the gallbladder ends. So that would be better. Shreya?
Right, sir. Always stand first whenever you have a jaundice or
If you are
cholangitis.
suspecting Mirizi with jaundice, always stand first. That is for
Yes.
sure. If it fails, that's a different thing. When can it fail? Stenting can fail. When will it fail? In patient of Mirizi syndrome.
Ma'am, sir, there is a impingement of the stone. The stent will not be. We are not able to pass stent above the level of obstruction.
Grade 4 Mirizi stone is completely obstructing CBD. Rarely it can happen. Most of the time stone will pass beyond it, but rarely it can happen. Then you have to
Yes.
go. Apurva, I think I will also leave. Thank you very much.
Yes, sir, we'll do then. Thank you, Shravan. Thank you. We'll do that.
Okay.
Thank you, everyone.
Thank you, ma'am.
Thank you,
Thank you.
Shreya, for that.
Thank you, sir. Thank you for inviting.
Thank you, ma'am. लीव कर दूं ना